Hello everyone. I welcome all of you to this insulin therapy workshop. I am Dr. E.T. Arun Thomas. I am going to lead this insulin therapy workshop for you on behalf of my sugar clinic, which is conducting diabetes education initiative. I have divided this workshop into 4 sessions. Before going to session 1, I wish to tell you the 6 principles of insulin therapy. Only if you are very thorough with these 6 principles, then only you can be a master in the insulin therapy. The first is you need to have thorough knowledge about the pharmacokinetic properties of the insulin. That means the onset of action, how long it will act, each insulin preparation. We have different types of insulin preparations now. Second, and very important, is common sense. Third is individualization. This is something very important here because a one insulin regime or one protocol will not suit all the patient. You need to tailor or individualize the insulin therapy for each patient. Next is, we all have to acknowledge that there is no fixed principles or rules. There is always a trial and error component involved in insulin therapy regarding the dose, titration, monitoring, everything. It is not like 3 plus 3 is equals to 6. It's not always true here. There is always a trial and error. And one should have good knowledge about insulin injection techniques. Then only you can teach the patient to inject the insulin properly. If the insulin injection technique is not correct, you are not going to get the good results. And lastly, self-monitoring of blood glucose is very important. Self-monitoring of blood glucose means patient has to have glucometer at the home with the test strips, and they have to monitor their sugars by their own, and we have to empower or teach the patient how to titrate the insulin dose based on this SMBG value. So coming to the session number 1, this is going to be a case-based discussion. I am not going to bore you all with boring theory classes. So this is going to be a case-based. Let me start with the case number 1. Here we have a 46-year-old male. He is newly detected to have type 2 diabetes mellitus when evaluated for polyuria and weight loss. Polyuria and weight loss are classical presentation of diabetes. His fasting blood sugar is 280. Postprandial blood sugar is 390. HbA1c is 11.8. So 46-year-old male, newly diagnosed type 2 diabetes mellitus. My question here is whether we should start on an oral hypoglycemic agent, OHA, or an insulin, tablets or insulin. For this, you all have to know that insulin therapy is a must if hyperglycemia is severe, especially if symptoms are present. Severe hyperglycemia means fasting sugar more than 250, random sugar more than 300, or HbA1c more than 10%. Here, look, our patient's fasting sugar is definitely more than 250, postprandial or random blood sugar is more than 300, HbA1c is more than 10. And also, this patient has symptoms, polyuria and weight loss. Additionally, insulin therapy is a must if patient is having catabolic features like weight loss or ketosis. This is a type 2 diabetes mellitus. Pancreas is able to produce insulin, but the cause for diabetes for this patient is insulin resistance. Then you all can ask me why insulin therapy is a must if these all are present. This is because, one, if the blood sugar values are very high in the blood, it results in glucotoxicity. the available beta cells or functioning beta cells cannot function properly and the secreted insulin cannot act properly. So this is called glucotoxicity. Here we need insulin even if it is type 2 diabetes mellitus, and even if you diagnose it, it's a newly diagnosed type 2 diabetes mellitus, if blood sugars values are very high because of glucotoxicity. With insulin, you can bring down his or her blood sugar very easily, and once the sugar values comes down, you can then later change to OHA. There is a common perception among the general public that once a patient is started on insulin, he needs to continue it lifelong. It is not true. If you're planning to start on insulin, you have to tell the rationale to your patient why you are starting. This is to reverse the glucotoxicity, and once you get a reasonable sugar control, you can change to tablets. Also, insulin therapy is preferred. Previously I told it is mandatory, but here it is insulin therapy is preferred. It is not mandatory, but it is preferred if HbA1c is more than 9%. The rationale is maximum HbA1c reduction with OHAs in combination is only 2 to 2.5%. If it is more than 9, it is very difficult to control it to 7, which is our target HbA1c, less than 7 with OHAs, because maximum reduction we can get is 2 to 2.5%. But since it is preferred, it is not mandatory, we cannot force the patient to start on insulin. Here, insulin can be started only if patient is motivated. Case number 2, here we have a 45-year-old male, is a newly diagnosed type 2 diabetes mellitus when blood tests were done as a part of regular health checkup. Previously, the previous case, patient had symptoms. In this case, patient do not have symptoms. His fasting blood sugar is 160, postprandial blood sugar is 260, HbA1c is 8.3. So my question, OHA or insulin? Here blood sugar values are not very high, HbA1c value is not very high. It is high, it is not very high, and do not meet the criteria for must insulin therapy, and also in criteria for preferred insulin therapy. So definitely he can be started with OHA. So when to initiate insulin, already I have discussed. Even if it is at the onset of the diabetes or at the time of diagnosis, if patient is having glucotoxicity or lipotoxicity, means the patient is getting emaciated with fats all getting destroyed because of the high blood sugars. Here we have to start insulin. Another theory fact about insulin initiation at the onset is, if you give insulin for type 2 diabetes mellitus, it can preserve the beta cells and prevent secondary failure to OHA. Because in type 2 diabetes mellitus, the pathogenesis for diabetes is actually insulin resistance. Insulin cannot act properly. So beta cells are actually functioning at the onset. It is actually doing more work. It is trying to produce more insulin to overcome this resistance. If you're giving insulin externally, beta cells do not have to do that much work. So beta cells will be preserved for a more longer duration of time. Also, if you get a very good sugar control at the onset with insulin or any other oral antihyperglycemic drugs, patients can have diabetic memory or legacy effect. So what is diabetic memory or legacy effect? It is the initial years after the onset of the diabetes, which is very crucial. If a patient has a very good glycemic control in the initial years after the onset of the diabetes mellitus, even if this good control is lost after a few years, but this benefits of good glycemic control in the initial years will be carried forward for 10 or even more years. So if a patient has a poor control in the initial years and a better control in the later years, he will develop microvascular. He is more likely to get microvascular complication. If a patient has a very good glycemic control in the initial years and less control in the later years, he's less likely to develop microvascular complications. So initial years is very important. So if the blood sugar values are very high, and if you feel that it is very difficult to control with OHA alone, you can consider insulin. It is a very common practice that we all start insulin secretagogues like glimepiride, glipizide, gliclazide, glibenclamide for patients with type 2 diabetes mellitus. These all are agents that squeezes insulin from beta cells. It stimulates the beta cells to produce more insulin. Already in the type 2 diabetes mellitus, beta cells are exhausted by producing more insulin to overcome the insulin resistance. And this insulin secretagogue acts like a whipping an overloaded donkey to take more load. So insulin secretagogue in the initial years of diabetes can accelerate the failure of beta cells. So till now I am telling the positive facts about insulin for patients with type 2 diabetes mellitus. But we cannot translate this into clinical practice. This is because if you're getting motivated by my positive fact, what I'm telling about the positive facts about insulin, and if you try insulin for your newly diagnosed diabetes patients, what will happen? It is not comfortable to take insulin. Patient need to receive needle pricks, and also insulin can result in hypoglycemia because of all, and also cost. Insulin is more costly. Because of all these reasons, patients can skip the insulin or treatment compliance will be poor. But what will happen if the treatment compliance is poor? It will result in poor glycemic control. So you initiated the insulin thinking that you will get a good glycemic control, but because of the fear of injection, hypoglycemic episodes, cost of injections, patient skips the insulin, and ultimate result is poor glycemic control. So this is called insulin paradox. So even though in theory insulin is a very good agent with a lot of benefits, it is practically not possible, or it is very very difficult to initiate insulin for a newly diagnosed patient. But you have to remember that you need, or it is mandatory to start insulin if the patient is having glucotoxicity, that is very high blood sugar, or patient is having catabolic features. For all other patients, for practical purposes, it is good to manage the patient with OHE. Case number 3, it is a 54-year-old male, is diabetic for 3 years, he is on metformin 1 gram 2 times a day, his fasting blood sugar is 250, postprandial blood sugar is 320. You are because of this high blood sugars, you are planning to start on insulin. I wish you to think about the best or ideal regime for this patient. 3 years diabetes, metformin 1 gram 2 times, patient is on fasting blood sugar, having fasting blood sugar 250, ppbc is 320. You can ask me, why can't we try OHA for this patient? You can try insulin secretagogues and other agents, but this patient is motivated for insulin and you are planning to start an insulin. This is a workshop and I want you to tell the best insulin regime for this patient. You can think for a few seconds. Then I will go to the discussion part. The most important principle about the insulin therapy is to fix the fasting blood sugar first with a basal insulin. Suppose a patient is having elevated fasting blood sugar and elevated postprandial blood sugar. Suppose with the basal sugar, if you fix the fasting blood sugar, postprandial blood sugar will come down automatically. Like here, fasting blood sugar is 250, ppbs is 320. Here, to control the fasting blood sugar, we need a basal insulin. Basal insulins are insulin which do not have much peak and have action more than 12 hours. So, If a patient is taking a basal insulin and controlling fasting blood sugar, suppose you control the fasting blood sugar of this patient to 100 using a basal insulin, then if you take the breakfast, the sugar surge will be only starting from this 100. So ppbs will become automatically 170. You don't need to treat this ppbs. Here fasting blood sugar is 250. After taking breakfast, there is a 70 surge in the blood sugar from 250. Suppose if the fasting blood sugar with the basal insulin you make it 100, with the 70 surge, that means ppbs is only 170. You need not treat this postprandial blood sugar with insulin. So you should not consider ppbs in isolation, post breakfast blood sugar in isolation. The most important value is fasting post breakfast blood sugar minus fasting blood sugar. If post breakfast blood sugar minus fasting is more than 100, then only we should consider this surge as significant. If this difference is less than 100, then you don't need to tackle the postprandial or post-breakfast blood sugar with insulin or any agents. You just need to focus on fasting blood sugar. If you fix the fasting blood sugar, ppbs will become automatically normal. So once again, this patient fasting blood sugar is 250, ppbs is 320. You're going to fix the fasting blood sugar with the basal insulin, ppbs will automatically come down. So what are the types of basal insulin available? 4 basal insulins commonly used are NPH, Detimar, Glargine and Degludec. NPH has duration of action 12 to 18 hours, Detimar 18 to 22 hours, Glargine 24 hours and Degludec 48 to 72 hours. Since the Detimar do not have 24 hours action, so once daily dose of Detimar is not very beneficial. So Detimar is now getting phased out from the market. So now the common available agents are NPH, Glargine and Degludec. NPH with duration of action 12 to 18 hours, Glargine 24 hours, Degludec 48 to 72 hours. Let us see the pharmacokinetic properties of basal insulins. Since NPH do not have 24 hours duration of action, if you want to get a 24 hours action, ideally NPH need to be taken 2 times. Now we have, and NPH insulin have a peak actually. It is not a peakless insulin. It have a peak after 8 hours also. Ideal basal insulin should have a flat curve. That means it should be peakless. So near ideal basal insulin is actually analog basals like Glargine and Degludec. Glargine having 24 hours action. Once daily prick is enough, we get a reasonable flat insulin level in our blood to control the basal sugar. It do not have much peak like NPH. And another difference I need to tell you between NPH and Glargine is NPH has got high variability in the blood sugar, results in high blood sugar variability. Like you are going to give a fixed dose of NPH to the patient, like 10 units every day and night, and you are measuring fasting blood sugar next day morning. Fasting blood sugar is controlled by the night dose of NPH. You are not going to get the same fasting blood sugar. Every day the fasting blood sugar will vary. Sometimes it will go high and sometimes it will go low. So variability is very high. Like in this graph, you can see blood sugar values are sometimes going more than 160 and occasionally it is coming below 70. Suppose you want to get a stricter glycemic control and you try to increase the NPH dose to get a more strict control, you will get a more strict control. But because of this high variability, patients can develop more hypoglycemia also. So intensifying the insulin dose intensifying the insulin, if you're using NPH, can result in more hypoglycemia. But this is regarding glargine or degludec, analog basal insulins. Here the variability is less. You can see with the same dose of analog basal insulin, blood sugar values are not fluctuating much. Even if you increase the dose to get a more strict control, you will not get much hypoglycemia like you used to get with NPH. So two analog basal insulins are glargine and degludec. Glargine has duration of action 24 hours. By the end of 24 hours, the action almost finishes. But degludec has up to 72 hours of action. The lower graph is of degludec. If you're giving degludec every 24 hours, after 3 doses, you get a steady state. You can see a steady level of insulin in our blood. But you will not get a steady state in glargine. But glargine is also a reasonably good basal insulin. Back to case number 3. Here we have a 24-year-old male, type 2 diabetes mellitus for 3 years, on metformin 1 gram 2 times. His fasting blood sugar is 250. Post breakfast blood sugar is 320. We only need to fix the fasting blood sugar for this patient. For this, we need to have a basal insulin. Only a basal insulin is enough. So you need to select the basal insulin. Based on my previous discussions, you will feel that degludec is the very best basal insulin because it has got duration of action more around 72 hours. After 3 days, you get a steady state or a steady state with a plateau or a constant level of insulin throughout 24 hours in our blood. So definitely degludec is theoretically much very superior. Glargine is also very good. Then NPH. NPH is not very good because it do not have 24 hours duration of action. And also glycemic variability is more with NPH. NPH, since do not have 24 hours, if you want to get 24 hours a basal insulin level in our body, patient needs to take NPH 2 times. So you need to give 2 pricks, or a more compromised way is to give NPH at one time, at least at night. But so the theoretical order is about the superiority is degludec superior than glargine, which is superior than 2 times NPH, which is superior than NPH 1 time. But this is the theoretical superiority order. But I have discussed you need to individualize the insulin therapy. Degludec is very costly. One cartridge of degludec, which has 300 units insulin, costs more than 1,000 rupees. This cost is 6 to 7 times the cost of NPH. The cost of glargine comes between degludec and NPH. If you start a degludec for a poor patient, he or she cannot afford. Immediately, he or she will skip the insulin. Or at least, or more likely, he or she will go to the pharmacy and hearing the price of the degludec, he or she will come back without even buying the insulin. But it is definitely a good insulin, basal insulin, for patients who can afford and who are motivated to spend more money for his or her health. NPH is very cheap. It comes under the price control of our government, central government. So pharmaceutical companies cannot increase the price of NPH above a limit. It is very affordable. So for common man, if you try to individualize, NPH can be considered superior and glargine comes in between. Okay, anyway, we are planning to start on basal insulin. You can select any basal insulin based on the patient preferences and patient's economic status. Next question, at what dose we have to start? a common or a simple formula or simple guideline I'm going to tell you. If fasting blood sugar is less than 200, start with 0.1 units per kg. If fasting blood sugar is in 200s, start with 0.2 units per kg. Fasting blood sugar is in 300, start with 0.3 units per kg. In 400s, 0.4 units per kg. Here, this patient have 60 kg and fasting blood sugar is 200, 250. So, patient's sugar is in 200s. You need to start 0.2 units per kg. So 60 into 0.2, that is 12 units. So what you're going to start? You're going to start degludec 12 units at night, or glargine 12 units at night, or NPH 2 times 8012 to get a 24 hours action. We are using 2/3 of the NPH dose in the morning and 1/3 in the night because NPH has got a peak, and that peak comes at around 8 hours after injection. So if you take the morning NPH 8 units, the peak will be around 2 o'clock, 3 o'clock time, so that it can control the post-lunch surge in the blood sugar also. But if the patient is not motivated for 2 times NPH, at least 1 time NPH can be considered. And something is better than nothing. That's a principle here. And how to follow up this patient? Suppose you are starting this patient with 12 units glargine. Then you have to monitor fasting blood sugar once in 3 days. We are going to keep a fasting target blood sugar of 90 to 120 for this patient. But this 90 to 120 is not applicable to frail or elderly patient. For frail and elderly patient, if you try to bring down the sugar below 100, sometimes the patient can have severe hypoglycemic episodes. So, for these patients, you have to increase the target. I will say 100 to 130. There is a typing error. It is not 130 to 130. It is 100 to 130 for frail and elderly patient. If with 12 units glargine, if fasting blood sugar is not coming to target, what you have to do? You have to increase the dose by 2 to 4 units. Then again after 3 days, you have to check. If it is not coming into the target, if it is below 90, you have to increase. If below 90, you have to decrease the dose. If hypo occurs, also you have to decrease. You have to reduce the dose by 4 units or 25%, whichever is more, if it comes below the target or if hypoglycemia occurs. If it is above the target, then you have to increase the dose by 2 to 4 units. Next is case number 4. Here we have a 56-year-old female. She is diabetic for 3 years. She is on metformin 1 gram 2 times. Fasting blood sugar is 300. Post breakfast blood sugar is 350. Discuss the ideal blood sugar. Here fasting blood sugar is elevated. You need to control it with a basal insulin. Post breakfast blood sugar is also elevated. This is 350. And the surge from the fasting level is 150. That is 350 minus 200, it is 150. So any surge above the fasting after a breakfast, if it is more than 100, that should be also tackled. So this patient needs a basal insulin and a prandial insulin. Fasting blood sugar is elevated. Post breakfast blood sugar is also elevated. This difference is more than 100. We need to target more. With a basal insulin, we fix the fasting blood sugar first. If you fix the fasting blood sugar, postprandial blood sugars will also come down to a reasonable extent. Then, with the prandial insulin, so prandial insulins are insulin taken before the food, and this have shorter duration of action, like which is a regular insulin, which is the classic prandial insulin we all use, which have a duration of action 6 hours. Taken before the food, it can prevent the blood sugar surge following the meal. So we target the blood sugar surge following the meal with prandial insulin. And how to monitor this patient? Ideally, we have 6 meal pattern of monitoring, which is fasting, post breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner. Suppose if fasting blood sugar is high, if a patient is on NPH, you need to increase the night dose of NPH. It will bring down the fasting blood sugar. If post breakfast blood sugar is high, it is not the absolute value. Post breakfast minus FBS if high, you have to increase the morning dose of regular insulin. If pre-lunch blood sugar is high, there are two options. Either you can increase the morning dose of NPH or a morning dose of regular insulin. If post-lunch blood sugar is high, you have to increase the pre-lunch dose of regular insulin. If pre-dinner blood sugar is high, that two way you can target it. You can either increase the morning dose of NPH or you can increase the pre-lunch dose of regular insulin. This regular insulin has duration of action up to 8 hours, so that can control the pre-dinner also. If post-dinner is high, increase the regular insulin dose before the dinner. And this is a 6-point monitoring. And additionally, we can check 3 a.m. blood sugars. 3 a.m. morning or 2 to 3 a.m. morning is a time where blood sugar values come down or hypoglycemia occurs. If hypoglycemia occurs at 2 to 3 a.m. morning, what will happen? Next day morning, blood sugars will shoot up. This is called Somogyi phenomenon. To identify it, you can even ask the patient to keep an alarm and wake up at between 2 to 3 and check the blood sugar. So this patient, in this case, the patient is having elevated fasting blood sugar and elevated postprandial blood sugar. Patient needs prandial insulin and also a basal insulin. Suppose you are using a regular insulin like 10-10-8 for targeting the postprandial surge and a basal insulin like glargine 10 units at night. You are asking the patient to get 4 pricks. You are subjecting the patient to 4 insulin pricks. This is not actually very comfortable for a patient. Suppose your patient is poor and you are if you are using NPH also, then also you need to target the patient for 4 pricks. 3 doses of regular insulins in the daytime and a bedtime NPH. 4 pricks. It is not comfortable. If you start this is called a Basal-bolus regime. If you start this Basal-bolus regime for your patients, what will happen? A good proportion of the patient will get irritated, or even if they accept it after a few weeks to months, they get tired of this increased number of pricks and try to stop the insulin by himself or herself, or go to some other physicians or go to some other alternative systems of medicine. To overcome this barrier, or this is another paradox, we have premixed insulin. So I will tell the concept of premixed insulin. Here in the basal bolus, what you are going to do, before the breakfast you are giving a regular insulin or a rapid acting insulin. It is called a prandial insulin. Analog insulins are also available. So any prandial insulin before breakfast, before lunch and before dinner, this will bring down the post meal surge in the blood sugar, and at night you are giving a basal insulin which gives a basal control. The another way is you can use premixed insulin. In premixed insulin, regular insulin which have a duration of action 6 to 8 hours and NPH which has duration of action 12 to 16 hours is mixed together in a fixed proportion. So a premixed regular insulin and NPH is taken before breakfast and before dinner. the regular insulin component of the premixed insulin taken before the breakfast will control the post breakfast surge in the blood sugar. The NPH component in the morning dose of the insulin, premixed insulin, NPH has a peak at around 8 hours. So this peak will be at around 1 p.m. to 2 p.m. It is at this time the blood sugar surge after the lunch. So previously I told one disadvantage of NPH is that NPH has got a peak, so it is not a very good basal insulin. But here, this disadvantage, we are using it as an advantage here. We are using this peak of the NPH insulin which we give in the morning to control the post-lunch blood sugar. And at night, we have a premixed regular and NPH. The regular component will control the post-dinner sugar. NPH will control the fasting sugar. But only concern is the night dose NPH, which is already come in the as a premixed preparation, has got a peak at around, and it will corresponds to around 2 a.m. 3 a.m. morning. So patients can have a hypoglycemic chances at this time. So premixed insulin, one example one common brand we all use is Human Mixtard, and common proportion of this mix we all use is 30/70. 30 means 30% regular insulin, 70 means 70% NPH. This is easy, less complex, and patient needs only 2 pricks per day. So I am briefing it once again. In the morning dose, 30% of the regular insulin will control the post-breakfast sugar surge. 70% NPH in the morning dose will control the post-lunch sugar surge. In the night dose, 30% regular insulin will control the post-dinner sugar surge, and 70% NPH will control the fasting. And how to titrate this premixed insulin? You have to monitor the blood sugar at 2 times, fasting and 2 hours post-lunch. This is in contradictory to the common practice, like everyone measures a fasting blood sugar and post-breakfast blood sugar. But the better or the ideal way to titrate the premixed insulin is the 2 sugar values which we need to know is fasting and 2 hours post-lunch. If fasting is high, you need to increase the night dose of premixed insulin. In the night dose, there is NPH. That NPH will control this fasting blood sugar. And 2 hours post-lunch, it is very important in our country because lunch is the biggest meal, and also this post-lunch sugar is controlled by the NPH component of the morning dose. Suppose if post-lunch is not coming in the target range, then we have to increase the morning dose of the insulin. Usual fasting sugar is target is 90 to 120, and post-lunch target is 130 to 180. This is actually a very strict target, but for frail patient, elderly patient with multiple comorbidities, better than you can have a higher target. With premixed insulin, a time period where you will get hypoglycemia is at around 11 a.m. and 2 to 3 a.m. in the morning. In the 11 a.m., hypoglycemia will occur because the regular insulin component in the morning dose have a duration of action 6 to 8 hours, and also NPH is also there. But at 11 a.m., the sugar surge following the breakfast is over. So there is no further source of glucose from our gut. And if the lunch is delayed between 11 to 12, patients can develop hypoglycemia. If this hypoglycemia occur, there are two ways to tackle. One is you can reduce the morning dose of insulin. But if you reduce the morning dose of insulin, post lunch sugars values can go high. Because if you reduce the morning dose, NPH component also comes down. But this NPH is needed to control the post lunch. A better way is to ask the patient to have a snack at 11 a.m. Patient do not need to make a new food items. They can actually split the breakfast. 2/3 of the breakfast they take at the morning and 1/3 they will take it at around 11 a.m. This is particularly very important for patients who takes lunch late after a delay, like they delay the lunch to 2 p.m., 3 p.m. and all. Next time hypoglycemia occurs is 2 to 3 a.m. in the morning. This is due to the night dose insulin which has NPH. NPH will peak at around 2 to 3 a.m. It is very important to recognize this hypoglycemia because patient is sleeping, dangerous complications can happen, and even if patient do not recognize this hypoglycemia, it will translate as a hyperglycemia in the morning called Somogy phenomenon. So you can ask the patient to wake up in the morning at this time using an alarm and check the blood glucose. And how to tackle this? If hypoglycemia is occurring, you have to reduce the night dose of insulin. That is one. Second is you can ask the patient to delay the dinner. Like there are patients who take dinner at very early, like 6 p.m. You can ask them to delay the dinner to 8 p.m., 9 p.m. If the patient is taking early dinner, you can ask the patient to take a snack at bedtime. Snack can be anything like biscuits, fruits, any health drinks, anything. Snack at a dinner. This all can prevent the early morning hypoglycemia. Thank you for watching. We'll have the rest of the insulin therapy workshop in the session 2.